So actually, when all is said and done, then comes the budgeting. So I think it is just fitting that the chapter on financing is the last and concluding chapter for today. This session will be chaired by, again, Dr. Shenoy Robinson, the Managing Director of Catex Health. Welcome, sir. And sir has been introduced to our audience, so I will take sir's permission to not read out his introduction all over again. The panelists for this session are Colonel Dr. Sajal Sen, a veteran of the Indian Army and Chief Operating Officer at Apollo Hospitals, Rourkela. May I welcome Colonel Sajal Sen on the dais. Dr. Manish Sabharwal, the Medical Director of Santosh Medical College. Welcome to you, sir. And Brigadier Dr. Pradeep Srivastav, sir, who's been introduced already in the morning. So welcome to all the panelists. I now hand over the proceedings to the moderator.
Thank you, ma'am. Last session, but probably, I think, at the end of the day, a lot of management people come to me, and they are senior management people, and they say only one thing: I wish we knew more about finance. That's one area that most of the hospital management personnel lack experience in, because they believe that that's the CFO's job, that's the accountant's job. That's not our job, right? It's unfortunate because somewhere your growth trajectory will stagnate if you don't know finance. You'll never be able to sit in a board position. You'll never be able to take up, advisory positions where it really matters. When I was medical director, I shifted from government to, and I will come back to you in a minute. I joined as medical director for this group, and I used to think, man, CEO must be a great job. He's got all the power, all the authority, and we are stuck here because of budgets and stuff like that. Then I became CEO, and then I became group CEO. I realized I don't have authority. The more senior you get, the more accountable you get. Then after CEO, I became, board level position. You realize that board is where the power lies. And in the board, the power lies with money, finance. So you think that the CEO has got a lot of authority, doesn't. They don't. For example, the HR budget will be created and they'll say, okay, we'll give you a 10% increase. That's it. Now in that 10%, all the increments of the staff will have to be, managed. And here you are, you're expecting 20% increase, 30% increase, 5%, and you land up with 5%, some bell curve, some HR guy will do something, and you are stuck. So when you look at authority and real power, it comes with money and finance. So never underestimate and underrate the power of money, especially when you are doing business organizations. When we go to government, again, money is what makes sense. And so everybody is hankering after budgets. So my colleagues here from government would talk about budgets. And if you don't utilize your budget, next time your budget will be cut. So finance is critical. And one of my CFOs used to say that finance is the lifeblood of an organization. If there's no blood, the organization becomes anemic. Eventually, it may even die. So that's the opening remarks as far as finance is concerned. It is critical, it is important, it is much neglected. And as hospital managers and administrators and executives, it is our responsibility to manage finances effectively. So I would like to, after the opening remarks, I would like to hand over the introductions to my fellow panelists, starting with Dr. Sajal Sen. Please go ahead and take some time to introduce yourself, sir.
Okay, I'm Dr. Sajal Sen. I'm ex-Army, but last 15 years I've been working in private sector. And I have been mostly in the consulting industry and making large Excel sheets and financial modeling for healthcare as well as social sectors, and in sometimes in the infrastructure side also. So a little bit of understanding of finance I do have. I'm still a learner, but I think I have, in the scale of 0 to 9, maybe I have learned somewhere, I've reached somewhere. Presently, I am heading a new greenfield operations of a public-private partnership at Apollo Hospitals, Rourkela, which is a joint venture between Steel Authority and the Apollo Group. So that's my brief introduction.
Thank you, sir.
I'm Brigadier Pradeep Srivastava. I've been working in Army for about 36 years before I actually retired. I went on working in a private sector and thereafter again joined one of the medical colleges, that's a government college. I've been involved in few of the projects in Army. That was about 1,000-bedded hospital in Southern Command and about 800-bedded hospital in Central Command. The requirement per se in a private sector and in a government sector are totally different. We'll speak about it in details. First, we have an introduction to be done here. Thanks.
Thank you.
Good evening, everybody. First of all, I'll thank Dr. Robinson for having me here and the SASH organizers for giving me this opportunity. I'm Dr. Manish Sabharwal. I'm currently the Medical Director of Santosh Medical College Hospital. Earlier, I was serving as the Facility Director. So, as the Facility Director and Medical Director, both I'm involved in the financial planning. As a curse, or whatever you may call it, we don't have a CEO. And prior to this, I was actually managing the emergency department. I'm also the director of MHA. I did my MBA from Drury University, Springfield, Missouri in US, and my specialization was business strategy and leadership. After that, I worked extensively in Delhi hospitals as emergency and ICU in charge. So that prepped me well for recognizing the needs of doctors and the departments and see the other side, now on the other side of finance. That's all.
Thank you. So I originally thought that we would, grapple with two questions. One is what are the risks that are involved with finance, financial risks of a hospital, and the other one was how to mitigate it. But I think somebody introduced a new paradigm into it that is really finance in public sector different from finance in the private sector. I've seen both. So before we go into that discussion, I would like to ask the audience a direct question. Be honest. How many of you really think that finance is boring? Oh my goodness, you guys are all disingenuous here. All of you think finance is interesting, is it? I am absolutely zapped. The first audience I've found, which is, I think you guys are disingenuous or you're really, really smart. Anyway, I think you're really smart because money is what makes the matter go. Only. So, there is a nuance that was introduced by my colleague here, which you said that finance in the public sector is very different from when we look at finance in the so-called for-profit or corporate sector. So is that really true? I'd like to get some views because we have quite a bit of people who have worked in both the sectors. Dr. Sen, would you like to give your opinion on, not just on whether it is or it is not, but how is it different? So what are the nuances, maybe 2 or 3, which actually differentiate private sector with the so-called public sector?
Okay, there is a very basic difference between private sector healthcare financing and public sector healthcare financing. Because in the private sector, whatever you invest, you have to get a return. The definition of business is that whatever you do, it has to end up in profit. And therefore, the profit has to be in tangible terms and mostly in terms of finances. In the public sector, it is more of again, it is a business and there is again a profit, but the profit is related to the public good, public goodwill, improvement of public health, and providing the care to the people who need through a subsidy from the government. So what happens is if there is a medical college, it is not given a mandate that I have given you 500 crores in a year, you have to earn 500 crores back. But if I am running a medical college privately, I will have to definitely look at it that there is a return on investment, there is an opportunity to finally, monetize the assets which I have created. Having said that, when it comes to accounting system in terms of private sector or public sector, I think the accounting system by and large remains the generally accepted accounting system. You will always have inputs, you will always have expenses, you will always have, depreciations. Everything has to be factored if you are running a smart business, whether in government or in private. Finally, when it comes to actually dealing with, the government versus private, I will end here to say that profitability in terms of monetized assets is something which is inescapable in a private sector, whereas in terms of the government sector, that definitely doesn't aim to be remain to be a goal. And therefore, we should not get away by saying that in the government we can do without, after all, the results have to be, the monetized results are improved health of the community, accessibility of the community, popularization of the government. There are so many things which are there. But the accounting principles will by and large remain the same. One last point, that there are also, not-for-profit organizations. Earlier, they used to be called Section 25. Now they called Section 8. So in that, normally people think not-for-profit means it is charity and he has to incur permanent losses. But that is not so. The government is moving towards, making accountable business units. And many cases, the government has done Section 8 companies to make sure that they have an income and expenditure statement, and these companies run, where the capex has been given as a donation by the company or any private investor. But finally, operationally, these Section 8 companies have to be viable. One of the examples is, in the afternoon, you had Dr. Deepankar. He was talking about AHI, Assam Advanced Healthcare Institute. That is again a Section 8 company, which will finally have to sustain its operational expenditure in long run. In my previous avatar, Assam Cancer Care Foundation, 17 cancer hospitals, again, the capex was donated, but operationally we are expected to make profits or surpluses so that we keep infusing the money into the system and saying. So that generally covers that the government is also moving toward income expenditure instead of simply giving a deficit budget in every institution.
Thank you so much. It is very, very well articulated. Thank you. Would any of my other colleagues would like to say something about the nuances of private versus the public sector?
As Dr. Sen was elucidating, there's also a third aspect, which is a private medical college. He was putting us under the same umbrella as private hospitals. I would slightly differ with that. I would say that the academic college also has a hospital to run, and there is cross-subsidization. There's no doubt about that. But at the same time, the leverage that a medical hospital can have due to the college is tremendous. I think we are currently in this country underutilizing the private medical colleges, and at Santosh we were able to demonstrate that we can separate the hospital in a way that it's both actually sustains and develops the infra as well as the capabilities in the long run. So what I think is that what we can do through cross-subsidization is one of the pillars of private medical colleges, and private medical colleges have to move in that direction slowly.
Thank you.
Yeah, a small addition to it. What's the difference between a private and a government medical college? I would add that shareholders have a lot of say in case it's a shareholder company sort of a thing. So a satisfaction to the shareholder is one of the very important factor in a private sector. Whereas in a government sector, if a service is supposed to be provided and there's a requirement, the finance viability may not be taken into account, and one goes ahead with this. So there's a requirement, there's a need of the hour which may overtake the financial requirements.
Thank you, gentlemen. I'll just sum up what I heard, and there's some very interesting nuances which I would like to, delve a little bit on. So there is private sector which is perceived as for-profit. There is private sector which is also not for-profit. Both of them have to make profits. One, to provide an ROI to the shareholders or the investors. The not-for-profit have to make a profit in order to sustain themselves, to ensure that there is enough money to upgrade the hospital, replace medical equipment, provide increments to staff. So a not-for-profit entity may not give dividends, but it still has to make money. And this is something that people need to understand very clearly, that if you are running a not-for-profit organization, you cannot afford to run it at a loss. Very, very important distinction. The other thing that Dr. Sajal Sen mentioned, which is, for me, it was like an interesting thing. He said ROI for public sector may not be monetary, but it is still there where we are talking about delivering health care or health to the community as such. So the ROI there is not monetary, but it is in terms of health, which probably would be a much better higher ROI, much higher value in return compared to just money. Right, sir?
Yes, I agree. And finally, daily adjusted years of life and how many $1 trillion you save by saving life, saving disabilities, or prevention of disease, that comes into the overall economy of the state. So it is an investment which the government makes to keep its population healthy so that it is deburdened from much higher expenditure and unnecessary burden on the healthcare.
Fantastic.
So that is also a ROI only. In
Fantastic.
financial terms, it can be monetized. Yes.
Very well said, sir. Very well said. Now, the question goes back to the audience. You have to decide how we take this forward. Do you want us to focus on the public sector or do you want us to focus on the for-profit sector? No, we can't do both. There is a limitation of time. So let's go for profit. I think the whole system is tilting. The audience wants more, focus on for-profit. So we'll focus on for-profit because we don't have the time to handle public sector. Sir, I understand, but I have to make a distinction. Which direction do I go? I can't keep on balancing between two boats. So we'll go with for-profit. All right. So my next question is, what are the financial risks that a hospital generally grapples with? What are the major financial risks that a hospital grapples with? So we will identify what are these risks. Is it of interest to all of you? Financial risk? Okay, understand financial risk because if in case your hospital which you are working in is financially unviable, it will close down. So what are the elements that go into making that hospital viable? I'm just trying to, flesh the question so that it's better understood. So I'll ask my colleagues here to maybe talk a couple of points on what are the financial risks that they have seen or encountered when they have been managing hospitals in the for-profit sector. Government hospitals, we'll talk about it a little bit later because there is an element of risk there also, which I might take a couple of examples on. But yes, let's talk about the for-profit, sir.
Okay, actually, you have to understand the risk in two phases. One is that if you are setting up a hospital, what are the financial risks what are the risk factors you have to keep in mind? What are the common risks which you have to keep in mind? So there are, in totality, the list is very long, but red, yellow, green if we take priority-wise. So if you are setting up a hospital in a state or a city, it starts from the first and foremost is the risk related to socio-political stability.
So can I just take a minute?
Yeah.
There are two parts to this. One is a financial risk when you're doing a new project, right? So there are two parts. New project, establishing a new hospital, what are the financial risks? Then I'm running a hospital, I'm operating a hospital, what are the risks that I see there? So sir, are you going to be focusing on project? Or are we,
I'll give both. Just give me some
so we'll
time.
keep it on, sir, we'll go one round and then we'll come back for another round. So this one is on project. We'll first go on project risk because that's what he started with, and then we'll come back to operational risk.
So if it is a project related, I think the first and foremost is you have to assess the socio-political stability of the area and see to it. Like recently, there is a disturbed state in the northeast. One of the very important promoters, they wanted to start a cancer hospital, which is delayed by almost 6 to 8 months now, and they have suffered immense amount of losses in terms of cost and time overrun. And also, the faculty which they had harnessed, they have also gone away. So much of almost 100 crores are sunk, and there is no return as of now. The second one is related to government, regulatory capacities. You have made your financial model as per insurance charges or self-paying charges, and suddenly the government cuts down the tariff and says, no, invariably you will have to do 50%. Like in West Bengal, they said that you have to take Swasthya Sathi at each and every place and each and every disease, and you are compelled to do so. So those kind of, when the government regulatory capping comes on the pricing, that also totally derails, and that risk you have to keep in mind, how the government policies are running. The third risk is related to what kind of, if there is an aggressive competitor somewhere around, and he takes away all your, basic clinical assets in terms of the doctors. So your asset, whatever you have invested, it becomes unutilized and it becomes perishable. Every day it is unutilized and crores of money is lost because you have a CTVS department, but you don't have a cardiac surgeon. He has run away and he's not there for 2 months, 3 months. Many of the linear accelerators have been lying dormant in this country because they could not get a good oncology team. So that risk you have to always keep in mind and harness the resource right in the beginning and keep the commitment, otherwise you will not be able to run. Fourth is wrong set of key drivers. Without having mapped the correct requirement of the community, people tend to make a highly futuristic investment. And I have seen many such hospitals, private promoters dying, and they are looking forward for marriage partners with larger group because they think that their practice was running, therefore the hospital will be full. They will make 200 beds and they'll not be able to fill up even 50. So that is over-enthusiastic conceptualization is something one has to, take account of. And the last and foremost important risk is the sudden shift in the cost of raw materials or import-export policies, which we have recently seen that the government had banned a lot of equipment coming from China and you had to route it through Singapore and other places. And that cost escalation is heavy. When I started a project, I started at 42,000 a ton for steel, and almost after 6 months, the price rise to 82,000. Just imagine how much money we would have lost in that project. So those kind of buffers and cushions have to be practiced before getting into a risky platform and not having, factored those kind of cost escalations.
So theoretically, there are four that Dr. Sen mentioned. I would like to ask my colleagues here, would you like to add?
Sure. I think the biggest risk is the existing competition and also what you're expecting the competition to be when you open. I think it's very important to do due diligence and identify your true clientele in terms of healthcare delivery, and also not erroneously affix the kind of medical care you provide in that area to something which is not going to be competitive in the long run. So if you're choosing, let's say, a cardiac care hospital in rural area, that will probably not give you ROI for years to come, and you have to really build on it. You have to commit to it for probably a long-term strategy. So you have to stratify what you're looking at in the short term and what you're looking at the long term for the ROI. It cannot be an integrated policy. The short term has to flow into the long run.
Yeah, I fully agree with you. The survival is one of the most difficult thing. And when you are wanting to survive in an environment where you are actually wanting to make profitability and do not run into a bankruptcy, naturally, you have to beat the competition. And to beat the competition, you have to minimize the cost, and also you want to increase the profitability, and the steady earning has to be there. If the steady earning is not increasing, what is going to happen is the profitability will slowly reduce and you will fade away. Your survival will not be there.
Thank you, gentlemen. So let me sum up on a practical note this round. So we as a company and I as an advisor meet with a lot of potential hospital owners or wannabe owners who want to build hospitals. There are different types of them, and you will encounter them as you know, some of us are very senior, so I'm not talking to you, sirs and madams, talking to the younger people at the back. You will find all kinds of people when you are actually talking to promoters. I want to build a hospital. Okay, you want to build a hospital? Great. Why do you want to build a hospital? Then they say, oh, we want to do social service. Some of them are candid enough to say, we want to make money. Okay, nothing wrong with it. So, what kind of hospital do you want to build? No idea. What clinical services do you want to run? Oh, we'll do everything. We'll do gynecology, obstetrics, pediatrics, dental, this, that, cardiac surgery. Some of them would like to do cutting edge. Okay? What kind of hospital do you visualize? Oh, it should be the best in class. You know, the world's best technologies and the world's best. This is a dialogue that I've had a number of times with promoters. And this is the crux of a financial disaster in the making. You need clarity from the promoter because you're going to be, or if you are running a hospital, why do you want to run a hospital? Why do you want to make a hospital? Number one. Number two, what are the clinical services that you want to run in the hospital? This is called a clinical vision. It is not easy to make. It is one of the most difficult things that I do, and personally in my company, I do it myself most of the times. Because clinical vision talks about exactly what services do you want to run in that hospital. If you want to do cancer, what cancer are you going to do? Are you going to do all the cancers? Are you going to run, let's say, cancer? So, organ specific? Yes. Will you do hematology? I don't know. Will you do bone marrow transplants? I don't know. Will you do all the three modalities? Surgical oncology, medical oncology, radiation oncology? Yes. Would you like to do nuclear medicine? I have no idea. Would you like to put a cyclotron? I never heard of it. So now you realize that clinical vision is not so simple. Your diagnostics, what kind of patients are you going to be managing in the hospital? Are you going to go organ transplant? All right. Organ transplant, will you put up a state-of-the-art lab? Okay, what does state-of-the-art lab mean? Will you put an HLA typing? No, sir, it's too expensive. How will you do organ transplant without that? No, I will outsource it. Really? So these are the questions that you need to get clarity on. First, your vision. Number two, your clinical vision. Clinical vision, the promoter will never give you. You have to do it yourself. And you need all your expertise, both medical and management. Third thing, architectural brief, which I don't want to get into too much detail. You have to tell the architect how many OTs, how many OPDs, how many wards, and this is based on numbers. This is not based on some gut feel that I'll do 12 OTs or 8 OTs. What's it based on? So again, you go back to the drawing board, which my friend said here, that you have to talk about volumes. What patients are you expecting? Case mix, patient mix. Patient mix is very important. Cash paying, government insurance, TPA. What else is there, yeah? There's one more, forgotten. Corporate, I don't know. So, each of this matters because that will define your revenue. And that will define what you are going. So, I'm just, we were working with a client. I'm just giving you practical examples and I'll stop in a minute. They wanted a premium hospital. Very clear, we will not make it for the common public. No scheme, no government, nothing. Only premium. So how does it translate? It translates into single rooms only, no double sharing. Your facilities change completely. Is there a risk? Yes. Tomorrow if the government says, you have to put in my scheme, where will you put them in? That's where he said, government regulation. So financial risks in a new hospital starts off with just the inability of the promoter to understand the vision and what they want. It's not that simple. The second thing that most of my colleagues here mentioned and I want to emphasize is over-optimistic revenue projections. In order for us to look good on paper, in order to us to draw investors, we project higher revenue, higher volumes. We know they are not going to happen or there's a risk there. But we will still project it. And that's when the story starts becoming really miserable. I don't want to get into what happens in boardrooms where a private equity investor is sitting because you have a term sheet where you have said, I will do this in the next 5 years, and there is a consequence if you don't do it. So if you don't make 500 crores in 5 years, the investor will take away 50% of your company. He'll take 25% of your company. Serious pressure in the board because your DPR and your revenue projections were very, very optimistic. So when I do my stuff, when I advise, it's extremely conservative. So to end the whole story short, the risk, as all my colleagues here said, starts with planning. And in the financial risk, the most important risk is what Dr. Sen said. One, regulation. Number two, patient mix. Or number three, over-optimistic revenue projections, cost escalation. All these things will ruin your hospital financially. Either it will close down or somebody will buy it. That's it. Anything else that anybody wants to add on project risk before we get into operations?
I think we can proceed.
Yep. Yes, sir. You want to say something? Yes, sir. Because the next part has got nothing to do with this part. Please go ahead. Can you give him a mic, please, or should I? Yeah, thank you.
About the practical part of the financial management, I was just to add my practical experience. See, most of our the hospital administration managers, see, we used to learn only the general concept of, yes, about the budget and the internal rate of return and this thing. But in the actual practical field, see, you will be added by deputy finance director, and then practically, yes, as we did not have the details of the different financial delegations of financial power, sometimes we are not much familiar with the details of the general delegations of the financial rules. So all our hospital administrator and the manager also should be very well conversant with the delegations of the financial power. And for the, yes, private bodies, private organization, yes, they may have the manager may have been given the authority to spend money here and there. But for the government organization, see, we are given major head, minor head, and in that way, for this digit, yes, that coding systems are there. So salary and the wages, then office expenditure, machineries, and the POL, petrol, and then vehicles. So in this way, details are there. And we cannot go exceeding the let down this one, the financial allocation. So we are very much limited. At the same time, our this whole concept of the tendering and this thing, in the every state, yes, following the delegations of financial power, they have the lower tender committee, higher tender committee. In that way, these all the official office heads in the government sector, it is a completely little not in touch with the real practical things.
So
we must be very much.
With due respect, we were focusing on not for profit. We were asked.
Yes, in the
Yes, sir.
government sector, it is not question of the.
So I'll respond. Because of sparsity of time, we were focusing on the for-profit. When we come to government sector, I understand things are different. See, in government sector, you're talking about delegation of authority and financial power, which is different. I'm talking about project planning and financial risk. We are talking.
Right, I agree. My question is that.
So, sir, allow me to finish. So, when you are making those projections of cost, who is doing it? It is the finance guy, right?
Right.
It's the finance guy, the accounts guy, the Indian Accounts and Audit Service, IAS.
Right.
Those guys will sit there, double AO, single, whatever.
They are there.
Financial
They are,
controller.
But
The point is, the operative input comes from the medical fraternity.
right.
And that's where we go wrong because we don't know it well.
Right.
And we listen to these guys who don't know how to run a hospital.
That's why.
I understand that, but the focus was on for-profit, sir.
Right. So
Thank you.
my question is, the ultimate conclusion is that, see, as much as we are concerned with the management of the hospital, so we must be well conversant with the minutes of the financial management, which is followed as per the delegations of financial power. And unless we know, then you will be full. You will be certainly full by the.
So may I answer it, sir?
This is the point.
So may I answer it, sir?
Right.
The thing is, in this scenario, when we are working in a government sector, sir, we should go back to the drawing board. Whatever we want, we should make it, and we should phase it in a manner. What is the money which is available? Based on that, we should phase our projects so that everything comes up, sir. Instead of going to the accounts and saying that this money is not there and we will not be able to and curtail the facility, instead of curtailing the facility, what we can do is we can go back to the drawing board, make the drawing whatever is required, and we phase the projects in such a manner that comes up in the second phase or third phase.
Thank you. Can we continue, please, because we have another round to go. So what I was trying to say is a lot of financial risk happens at the stage of just creating the project finance documents. And later it translates into serious pressure on the chief executive officer and the marketing guys and everybody in the system because your financial projections were not correct. You had no clarity. It's a disease which continues to plague you. It's like a cancer. You have to eradicate it. First of all, you need to prevent it if it's possible. If it happens, then it's a problem. So that is a major financial risk. As you go out in the world, you will realize that this is one thing you have to be very, very careful about. Extremely careful. People talk a lot of rosy pictures, but when it comes down to the financial reality, it hits them in the face. I've talked to people who are talking about 5,000 crores, 3,000 crores, but when we actually lay it down on the table, they're not ready to spend 500 crores. So they'll talk big, but when it comes down to actually spending and realizing that the IRR is going to be poor, they actually hold back. So that is one of the responsibilities we will have as we go forward. Now we come down to the hospital operations. So you want to say something? Okay. I've been asked to cut short this session because it's boring. Everybody wants to go home.
There's one aspect which has to be started in the very beginning, and that is no one has spoken about the survey, the feasibility.
Sir?
Feasibility of the project or the hospital.
Financial feasibility.
No. Survey regarding the geopolitical, the population, the type of population. No, that is not mentioned. You see, when you're planning out a hospital, you have to see what sort of population are you catering for, number one. What is the competition available in the local market?
Correct.
So that aspect gives you what type of hospital, what type of disciplines will you plan for.
Correct.
And the cost obviously correspondingly changes. So it starts always with a survey. At least that's what I've been doing.
Yes.
When I was doing for Fortis and Max, the first thing I would do is carry out a local survey. If we can't do it ourselves, there are people available in the market to do it for you. That is how it should start.
100%, sir. I take your advice. Yes. So when you are making your projections, when I talked about that, I assume that a market survey would be done, but you're right. Without market survey, nothing happens. And we generally outsource it. Very good, sir. Thank you for bringing that up. Thank you. We'll move into operations of hospitals and what are the financial risks that we are talking about. Dr. Sharma told me that you focus on one area here. So I'll bring this whole discussion there, irrespective of wherever you guys take me. So when you're running a hospital, what are the financial risks that we face? Let's start from there this time, Dr. Sajal. Yes, sir.
So the biggest financial risk in operations that you face is unexpected occurrences like COVID happened to us.
Okay, so unexpected disaster, one.
Second is that if your revenues are not up to the mark, you cannot grow and you stagnate, and by the virtue of that.
So revenue stagnation, number two.
Number three is if you are not able to sustain your expenses, that is the biggest challenge.
All right, so an inability to manage operating expenses. All right, so three of them, anything else?
No,
a similar sort of building or the hospital comes up next to you, there's a competition which will develop. And when the competition is there, how do you sustain yourself? That becomes a very, very important aspect.
Yeah, especially if the competition takes away your doctors. So very important. Yes, sir. Sir.
I think my co-panelists have given the causes of the incurring losses. And I would rather say that they are causes of the risk. They are not the risk per se. If you are in business, you will always have competition. And if you are in business, there are ups and downs. So those are causes. But let me, quickly enumerate some of the risks, financial risk if we are talking about. The first and foremost financial risk is if you are doing credit business, whether in government scheme or CGHS or corporate or PSUs, the swelling receivables. There are hospitals who have receivables up to 100 crores, 200 crores also, which have been piling up for years together. And you can imagine the cost of capital and the cost of money which is involved, and that money is not coming back, and you have to pay your vendors, you have to pay pharmacy, you have to pay consumables, but you are not getting that money. So one of the risks which you have to very critically track in a hospital if you are a manager is the credit risk and receivable risk. That is number one risk. Number two risk is the second one is related to the suddenly you are not updated and you find that under the carpet your cost of operations have swept in and they have started increasing. Because many clinicians, many surgeons, they tend to use a certain high-end consumables which are incurring a cost in your package surgeries, and then at the end of the day you find that you have done volumes of 100 cholecystectomies, but probably in none of the cholecystectomies you could make money because the consumables which you have used as per your costing pattern is very high, and therefore you have no margin. But that will only come when you close the finances of the quarter and you suddenly realize that you have so much of volume of business but you don't have. So the second risk is to keep a track on the consumable cost. The third risk is related to HR cost, which a running hospital, a matured hospital over a period of 7, 8, 10 years, we tend to keep integrating more and more people. And we keep differentiating one man, one job. And then we realize that all those have got 6%, 8% increment over a period of time. And they do not have that kind of, utilization of 8 hours. And then suddenly you find your HR budget, which is supposed to be 22, 25%, has gone to 34%, 35%. That is the time either you expand and reshift them, or you will have to find ways and means how to get the best out of those. And the fifth risk, which is a common risk, is leakage of business. Once you have your clinicians and doctors on board, many a times what happens is you have gradually increased your pricing of your surgeries, packages, beds, because you have to sustain. And suddenly they find that there are patients who are not affording, they want cheaper, so they will try and start operating in the nearby nursing homes or nearby somewhere other places. And you will suddenly find a shift of patients going out of your business, which is called a leakage risk. So again, to summarize, one is the receivable risk. Second is your cost risk, which is incurred. Third is your HR risk, which you cannot track. And fourth is the related to the leakage of business, which is very common. These 5 things actually plague the business. You will find hospitals with 75% occupancy also making a margin of 2 or 3% EBITDA at the end of the day. That is because they have not controlled their cost. So the risk involved is on these magnitudes.
Thank you very much. It was very, very well articulated by Dr. Sen. I want to focus on two things. What he mentioned was accounts receivable. How many of you understand accounts receivable? Oh my goodness. I think we'll have to do a little bit more on the MHA part. Finance is weak. They don't understand accounts receivable. Okay. Cash flow management is critical. Do you understand cash flow? Oh my goodness. Thank you. Somebody said yes, thank goodness. So revenue has nothing to do with cash flow. Do you realize that? So when you are doing a profit and loss account or what you call an income statement, you will see revenue on the top, and then you will see direct costs, then you will see gross margin, and then you will see operating expenses and then EBITDA, right? That top line, which is the revenue which everybody is focusing on today, is the risk, because it is not necessary that that revenue is cash in the bank for you, which is what he mentioned. So cash flow management can actually bleed your hospital to death. And there are enough small hospitals pre-COVID who were literally bankrupt because their accounts receivable were so high that they couldn't manage the accounts payable. I don't want to teach you finance, but please understand what he was trying to say. You keep on doing business, which is credit. Credit business from government, credit business TPA, credit business from I've forgotten. ECHS, which is one of the worst payers, by the way, in my time. And then, lots of others, CGHS, whatever. You keep on doing them. Your revenue is showing top line, which is growing. But cash is not flowing in because you haven't got paid for it. Your accounts receivable should be 90 days. It's 120 days, 180 days. There are some of the accounts you know that the money will never come to you. How many of us in operations are focusing on accounts receivables in the private sector? I'm not talking about the finance guy. Not many. Not many. Because cash flow management is supposed to be a treasury function managed by the CFO. So this is how he manages. If there's cash coming in, then there is payments to be made, including doctors' payments, including your salaries, including vendors' payments. There's not enough money in the bank, irrespective of the revenue, he'll not be able to make those payments. So what does he do? He goes and raises short-term debt to tide over that payment till he gets that money. So he's managing cash. This is called cash flow management. Please, if there's nothing else you understand cash flow management in future, you will be a rock star. If you can master this, accounts receivable versus accounts payable. Because a lot of us believe that it is accounts function, it is, but if you know it, you will become a rock star. So thank you for bringing that up. The other thing that he mentioned is gross margin. How many of us are medical directors and are tracking gross margins on our surgeries? Very few. Fortis was doing it. I'm glad you are doing it, sir. Every surgery we used to look at the gross margin. What is gross margin? What is the money that you have raised for it? What are the direct expenses? Direct expenses can be broken into two: medical and surgical consumables, meds, and the third one is doctor's fees, in case they are a fee for service. Even then, for accounting purposes, we put doctor's component in that. That is your direct expense, and then is the gross margin. If your gross margin is below 50%, be careful. Only in high-value surgeries can you afford it to be below 50%, like liver transplant. But if it is a small surgery, as you mentioned, cholecystectomy, 50, 60,000 bucks, 1 lakh, 1.5 lakhs, and you are only making, let's say, 50,000 out of your 75, is going to be a disaster. I did an analysis on pediatric cardiac surgery for a hospital. Every surgery, they were having a loss, and the volumes were high. So the promoter said, we are going to stop doing pediatric cardiac surgery. The guys were very upset. They said, it's our bread and butter. We are doing so many surgeries, 3 in a day, blah, blah, blah. But on every surgery, you're making a loss. Take a call. So these are two important things that we want to actually emphasize here. One, cash flow management. Number two, gross margins. These are ones that can kill your hospital, even if it is showing, great top line and a great, your marketing guys will be very happy. They'll say, sir, revenue बढ़ रहा है, sir, देखिए हम कितना लाए. अरे बाबा, where is the cash? Credit में तो आप जितना मर्जी business कर लो ना. How does it matter? So, those are the two things I wanted to emphasize. Thank you, my panelists. Is there any question that you want to ask? Very boring. Two things. Yes, sir. No, I'll give it to you, sir. I'm nearer. Oh. You're having a race.
Excellent discussions, and I couldn't hold myself back because you were provoked, actually. The kind of illiteracy that exists within the medical community, and including, I would say, because we cannot be out of the medical community, hospital administrators included, and some of the civil servants as well, and owners as well. Financial illiteracy is disastrous. So the planning should be that financial literacy should be promoted by all hospital owners as a planned activity. Take, for example, the consultants. They are the most financially illiterate people. Their only focus is what they do get for the procedure that they do. And it goes on and on.
So they have a skewed financial literacy.
Yes.
What is
I know that. What is in it for me?
Everything.
I know that. And that's deliberately, they will flaunt that I do not know, I don't have to do anything with you. But there has to be face-to-face, transparent discussion about money. How much revenue, and it's not sin to talk about it, because you got to talk in terms of sustainability and growth. And people, I don't know why profit is a sin. Profit is, I think, the fruit of labor, which actually has to be deployed for sustainability and growth. Without growth, how could you expect the healthcare sector to grow and health to come into wellness domain and from illness domain? Is it possible?
No, sir.
When the investment flows into wellness domain, only then it becomes sustainable. There's no money for wellness today. It's only for illness, and that's a disease.
True, sir.
So every owner, every consultant, every medical director has to face the money part of his activity, and let's call it a business, because it's actually a business of managing ill health.
True.
So it is not a sin to talk about money. In fact, it's good that for after a long time in SASH, we are talking about brass tacks. And it's in Section 8 you mentioned. Government of India is actively promoting this, because you got to have active look at your balance sheets.
Accountability.
You got to make the balance sheet transparent, and everybody down the line has to understand what does it mean. Take, for example, each procedure has to be costed. Unless you cost it, how would you convey that you are reducing cost over the years? Unless you start disaggregating the data per procedure, it cannot actually help you in finding out where the costs could be contained. Once you contain the costs, it becomes more viable, it becomes more sustainable, and then your whole focus changes in finding out more procedures where costs could be contained. This entire process makes the entire hospital by a small activity of looking into. It's like, again, the word financial literacy. Look into, and the people have to be forced to look into money. It should be considered as a religion, I would rather say, in hospitals. Hospital administrators who do not read the chapter of financial management, I would say they cannot call themselves as hospital managers at all.
So they will not grow below senior managers.
Absolutely. And Mr. Gadkari's address yesterday was prophetic. There's a lot of money available. But how money would be attracted unless you have a business which gives profit? How would investors, you were telling, they were not willing to invest. Why? Because the message is, it requires 7 years break even, it requires 10 years break even. Why? Why can't you build a project where 3 years break even is there and you show profit, more money comes in? if IPO comes very late in health sector. Why? It could come in 2 years. And increasingly IPOs are coming in health sector. That's the brightest.
MSME IPOs.
If you see
MSME.
startups in health sector and very successful IPOs are there. People are there to shell out their money because they know there is money in it. Thank you.
So 2 things came up here. I'll come back to you. I will. Please hand her a mic, please. Thank you. So, we are talking about things. There is one thing that I'm asked a lot of times. Can you please, there's a lady there who wants to talk. Can you please, refer a CEO or a medical director? Do you know that how difficult, okay, I have never in my life till date been able to refer a medical director for a hospital. I'm being honest with you. The medical director's position is a critically important position in any hospital, and I find most of our medical directors fall short because they don't understand finance. The medical director needs to know finance more than probably the CEO. Number one. Number two, they need to track cost, medical costs. That's 18 to 22%. That's huge. And it's totally in the hands of the consultants. The consultants can break you on that, which he said. They can actually destroy your profitability because they are not being tracked, they are not being monitored. In one surgery, they can waste $5,000 worth of sutures and consumables, waste, because there's nobody tracking them, nobody asking them questions. So that is the medical director's position. In the US, it's called Vice President Medical Operations. The most powerful position, he's more powerful than the CEO. Do you know that? In the US, VP Medical Ops. But in India, medical directors, unfortunately, don't take this seriously. If you can manage this piece, financial part of the medicine of the hospital, believe me, you will have power. People will respect you. It's because we don't have it, people disrespect us. The CEO gets power. Just a nuance. Just this last question, and I'll come back to you. How much money should a hospital make your EBITDA? I mean, what would be a nice EBITDA? I know I'm not talking about 40%, but what do you think is a decent EBITDA for a hospital? Just a question. 10%? Come on, tell me, yaar. Numbers, 10%? I'm just a, sir? 18 to 20%? Anybody else? Sir? 25? No, how much would you be comfortable with? I'm not asking what's possible. 25%? Okay, good. So within this audience, I have a range of people who are expectations vary from 10 to 26%. Well, interesting. I mean, everybody wants 30 plus EBITDA. Yes, ma'am.
Sir, I wanted to ask, how much is market risk important as finance? Sir, how much is market risk important as financial risk when we consider healthcare? Because market risk is something which I feel we create. So how much is market risk important as financial risk?
Somebody like to answer that, or I'd be happy to answer.
You mean to say market risk?
Market risk.
Market risk is basically you are talking about that if there is a competition or there are more facilities come up and therefore you will lose business. Is that what you want to say?
Yes, sir.
Exactly. Now the question is that the market is always growing. Market does not diminish. Once you have set up a property or a hospital, the competition will be always there. There is no question of having competition. That competition is only going to take a certain market segment. If there is a market segment by the percent by 100, you have to plan that in so many years, what will be your market share? And you should stick to that share based on your business model, how much money you are going to make out of it. So therefore, I do not think there is something called market risk. Competition can damage or harness you by taking away your clinical assets or by suddenly you're making a void in your hospital. That is a risk which I am going to sell you. But the patients and the people, if your service is good, you are accessible, you are affordable, and you have a good reputation, your market share will never go. Whatever you are, you will remain. In fact, I would promote that if you have a hospital, there should be more facilities come up because it will attract more clientele. and it will give them more choices and options, and you will definitely grow in your business instead of being just a unique hospital in one place. So therefore, there is nothing called market risk by competition. Competition will be always there. You have to keep upgrading yourself, redefine your products and services, make sure that you have a decent reputation and the right kind of clinical program. There is no way that a competition can kill you. Competition can kill you only if he poaches out your drivers. That's it.
I would like to interject there. I think when we talk about market risk, it's also, there are two components to it. Second component is the financial environment risk. The environment around you, your currency may fall, your equipment are, as yesterday was discussed, mostly imported. So replacing them will be higher cost. There is also environmental risk when you are actually, your GDP of the country falls and you have a, let's say, more inflation. So the real prices go up, the salaries go up. All those financial risks are actually the environmental financial risk. And we have to plan for them. There has to be a mitigating strategy for them.
Let me talk about market risk for you. There is a Deloitte principle which talks about the 4-25% rule. According to them, any market can accommodate up to 4 players. And the smallest player will be 1/4 of the largest player. And all of them will be viable. I don't know whether it made sense. Every market can manage at least 4. So think about it like that. And the second thing I want you to think about is when we are looking at advising investment in startups or in any industry, and the person says there's no competition, no investment. Because you are too risky. Because you think you have hit this brainwave. That's probably not going to succeed. If there is competition, it gives a lot of comfort to the investor and to advisors like us that, boss, yes, this is viable. So competition is not bad. Competition is good. It depends on how you look at it. Anybody else? Any other question? Oh, I didn't know the finance would go on. I'm so sorry, Brigadier, Sir General, sir. I've been asked, this is going on. आप बता देना कब बंद करना है, मैं बंद कर दूँगा. आपके ऊपर है, sir. आप हाथ उठा दीजिएगा. Yes, ma'am.
Sir, my question is to Sajal, sir. So it spoke of financial illiteracy among doctors, and that definitely adds on, from your gross margin and, the consumables, which adds on to it. What do you think about bringing in financial literacy at the graduation level with, bringing in, because that is not something we are taught as doctors. There is nothing. You only learn about the anatomy, physiology, medicine, surgery, and other skills. Would it be, at this stage, recommendable or, advisable to bring in some form of financial literacy where when these doctors are ready to be out in the market, they do think in terms of monetary, and it is no sin to think about profits, like Sir said. So your thoughts on that?
No, I think, teaching finance to medical undergraduates may not be a great idea because you are being taught the basic statistical tools and other things. If you go to community medicine, the Park book also, there is about a public health sector and finances. Some amount of it is given. I would take a lead from Dr. I.B. Singh's point of view that how are we going to, basically he's saying that how am I going to budget? The budget is made by somebody else. With more due respect, I beg to refer a little bit from him. Actually, in the early 90s, there was a concept in the government called zero-based budgeting, where they said, when Rajiv Gandhi became the PM, he said, let me have a zero-based budgeting. The idea was that each function, each department was told that you don't have to look at what you have spent last year. Make a dhobi list, laundry list, how you are going to spend the money next year, what kind of budget you want. So that the data is more pragmatic, realistic. Now coming to hospitals, I don't think what happens, we as doctors or hospital administrators, the moment the chartered accountant wants to teach you the balance sheet, the IRR and the net worth, how do you calculate, and all the basic financial parameters, you tend to get confused. That is not your take. If you know it, like people like us, we have learned the hard way, that's okay, that's a feather in the cap. What you should be conscious about, is how do you cost your operations. Until and unless you know how you cost your operations, there is no way you will be able to control. So you should know the cost elements of an operation theater. You should know the cost elements of a ward. You should know the cost elements of a ICU. And once you make the laundry list, you will find how many cost elements you actually must have ignored. There are lots of hidden and latent costs available. Keep writing them and keep apportioning a value to it. You will come to a budget, you will know that where you are spending, that is the literacy which I am talking about. And that becomes your basis for budget. And that is how you can then do your business planning. After that, your accounts guy who knows better to run the Excel sheets, he will give you the inputs of cost and inputs of revenue and inputs of data numbers, that how many surgeries you will do or how many you can apportion based on the socio-demographic profile, the epidemiological profile, the market survey. Because what we tend to do is we simply have a last year budget, we tend to increase everything 10% when you say कि budget ho gaya. That is the wrong way of doing things. You should put up your mind and sit down, and it does not take more than 2 or 3 days to find out about each place. Once you do that, there is no way. I think in hospital and management curriculum, many people have done costing studies, particularly in AIMS, where I belong to, my teachers are here. So there are a lot of costing studies they have done and they have inculcated. Few years back, even Dr. Siddharth had called me, couple of years I have gone and taken a 2-3 modules on financial management. I call it finance for non-finance. That is I recently wrote a small book also, Finance for Non-Finance, because I found that it has to be simplified to a level where you can actually understand and add value to your financial projections. You need only that much. There are people who will do it for you. But if you give wrong input, you will get wrong output. So basically, cost element is something which you have to be conscious of. I think we end here. And,
So just one question. Sir?
I just want to say one thing. Yeah, sure. Accounts and finance are two different things. You just want to say, you have a question?
Please, sir, if you permit, sir.
Give me a second. I just want to emphasize one point which I think needs to be emphasized on. Financial literacy. Accounts and finance are not related. So when we talk about financial literacy, are we talking about accounting or are we talking about finance? I think doctors must know finance. I think, this is my opinion. At least the basics of finance. Accounts, you can hire an accountant to do it, yeah. It'll cost you 15,000-20,000 bucks. That's it. But the accountant should know, the boss knows. And as he rightly said, a medical director's function, I don't know, how many of you are from Fortis? Fortis, sir. We have 4-5 guys. So, Fortis had, in my opinion, about 10 years ago, one of the finest financial systems. Their budgeting was absolutely immaculate. Fantastic work done. I don't know whether they're still following it. I don't know. I'm talking about a long time ago. And a lot of that input in the budget came from the medical director, which happened to be me at that time. So the finance guy came to me and said, "Ye bharna hai." I said, "Mere ko nahi pata ye kya hai yaar." Then he actually insisted. So I sat down with him and he rightly said, I used a bottoms-up approach, which I even use now when I'm making a DPR or any Excel sheet. So that is critical, and that doctors need to know if you're sitting in a medical director's position. I'm sorry, I'm being hard on this, but it is my biggest lament that as my colleagues who sit in medical director's position in a boardroom, they get lammed. And I feel so sad for them because they're my colleagues here and they are getting lammed by a finance guy. It's not right. Yes, ma'am.
Sir, following up on the previous question that undergraduate students in MBBS should be taught finance, I would like to submit, if the House considers it prudent, to at least start hospital administration as an undergraduate subject in MBBS in order to orient our young medical graduates towards this wonderful specialty. This is the correct forum, sir. This is a long-held dream of mine. And this is a request as well as a question for this House and the seniors to consider. It's high time that hospital administration found a place in the MBBS curriculum all over the country.
How many of you vote for it as yes? Please raise your hands. Everyone. Okay, we have 90% people supporting you. Congratulations.
Thank you, sir.
Any other question from the audience before we close? I'm yet to see a hand. So you have to leave. I'm yet to see your hand, sir, if you ask me. Otherwise, I'm done. Any question? One question? Okay. I didn't know finance was so interesting. I thought it was generally boring.
Good evening, sir. So myself, Dr. Sunil from Border Security Force. So one point was discussed that there are problem related to the credit bills in the corporate hospitals which are related to ECHS, Ayushman Bharat or other TPS, sir. Now to deal with such problems, what could be the ways? If you can highlight any expert opinion, sir. Because there are, both people are sitting, experts from government sides, policy making, and from corporate, sir.
So would you like to answer that?
I'll answer that. Actually, you have to understand two things. Swelling receivables are invariably 100% not attributable to the companies or the creditors who have taken the service. I have done some research work on this for a couple of hospitals, and I found in 60-70% cases, the hospitals were themselves at fault. Because the credit billing system, they have not followed the process, they have not given the right kind of documents, they have not, and in many cases, they have submitted the bills after the limitation period is over. 50-60% is attributable to these kind of errors only. And then they keep fighting saying that my bills are there because somebody has left it to the lowest of the person, the credit copy maker and the credit bill maker and the billing assistant. They make bills in any form. They are not matching with the discharge summary, and therefore they are not being passed and they are under observations. And these are one of the common causes. That's why I said keep a track and make sure your credit bills are accurate and they are following the right procedure which is being done. People blame ECHS, but let me tell you, in ECHS also we did a study and we found 50% hospitals did not comply with the requirement of the billing process. And that is why they were not paid. It was not always a budgetary problem or somebody was not paying, number one. Number two, credit has to be tracked on a monthly basis. And you have to raise it to the light forum, raise it to the people, raise it to the creditors. Or at times you can even, like many hospitals have done, you even stop credit business with a particular credit liner if they have not given. Because sometimes it is the other way around. Somebody has not been paying because they feel it is their right to keep your money. So in those cases, you have to put a stop there. And once the client starts pressurizing them that we want to go to X place and why it is not been done, automatically the funds are also released and the mitigation takes place. The trick lies in right billing and tracking it on a monthly basis. That is how you can mitigate this risk.
Thank you. Would you like to say something?
Yeah. I will add on to this. We found the same thing happening when I was in service. And what we did was we made an exhaustive checklist. And this checklist, we attached the checklist along with this document. And we found every bill was getting passed. So if you are making an exhaustive checklist and you are attaching it with that, rest assured that your bill is going to be paid.
I think I've handled those bills myself for a long time. There's truth to the fact that, yes, there are errors, but I think the best advice here would be to put your best doctors to answer the queries. I think that is a very important point. The queries will always be there, but if we answer them expediently, and the person who's answering those queries should know the nature of the biller. So knowing the nature of the beast is very important before you tackle the beast.
So I just want to ask a question. How many are aware of a term called revenue cycle management, RCM? Very few people. So RCM is the heart of what you're talking, revenue cycle management. It takes into account a lot of things. One of them is this. And Dr. Sajal Sen put it very clearly. The problem lies with us. And when do you think billing starts? By the way, we did a program for Apollo. I mentioned it in the previous thing. It's called Apollo Way. We used it on Lean Six Sigma thinking, and we created a whole process on that. I don't know where it reached. After I left, I think everything rolled back, if possible. But when do you think billing starts in the patient flow? So do you do PFAS and all, patient flow process? Anyway, where does billing start? At the time of? Okay, sir, at the time of admission, anybody else with a different view? At the time of? Sorry, one person at a time. Empanelment? OPD? The billing starts when the doctor writes admit. And then your whole process starts, whether it's for surgery or whatever. You have to go and, create a complete process on it, which he very rightly said, checklist. And unfortunately, most of our hospitals leave it to the lowermost executive. That poor girl or boy keeps running around the consultants. Sir, ye likh do, isse sign kar do, sir, ye kar do, wo kar do. The consultant couldn't care less. So there are different systems you can create, sir. When we used Apollo in Apollo, one of the things, I'm talking about practical stuff. Every patient had a board attached to them which said this is the time the patient will get discharged. Except for medicine patients, most surgical patients, we know when they will be discharged, 3 days, 4 days, 5 days. And the whole system knows that this patient will go on Friday. And therefore, everything in the documentation starts working to ensure that the patient leaves on Friday. And your billing reconciliation happens at midnight. You have to put an accounts guy, sitting in the night who will go and do the reconciliation every day for every patient. So there are these systematic changes you can make, checklist, focus, which will ensure that your accounts payable, accounts receivable is minimized. I'll not say it will be eliminated, but it can definitely be mitigated to within 90 days. It's a lot of painful work, a lot of hard work, but it has been done many times in many hospitals in India. It's not rocket science. Anybody else? Okay, gentlemen, thank you so much, ladies, for your time. Thank you, gentlemen.
Thank you so much, sir. A big round of applause for our moderator and panelists who have made the last session, I think, the most vibrant and interactive one. You'll all agree with me on that, I'm sure. So in order to formally thank and felicitate the moderator and panelists, may I invite on the dais a very senior AHA Life member, Brigadier Dr. S.K. Bhatnagar, sir. The first felicitation to our moderator, Dr. Shenoy Robinson. Thank you so much, sir. Our panelist, Colonel Dr. Sajal Sen. Thank you so much, Colonel Sajal. A big thanks to Dr. Manish Sabharwal for his participation in the panel. And finally, our panelist, Brigadier Dr. Pradeep Srivastav, sir. Thank you so much, sir. Please come forward for a group photograph, Shenoy, sir.